Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast. I'm Dan Carter here at Countryside Equine Hospital. I got Dr. Tori Martin with me. She's one of our newer veterinarians here. Just started about 2 weeks ago. I think y'all have seen her before on the podcast. For those of you watching on YouTube, we've kind of changed it up a little bit. We're sitting in some chairs without a table, and I feel a little Ricky Bobby-ish here, except I really don't know what to do with my hands, and now I don't know what to do with my legs and my feet. So y'all bear with me here. Feels a little different. So how are you doing today, Dr. Tori?
I'm doing well. Excited for the day. Excited to do a podcast with you for the first time. Talking about a great topic. So
yeah, let's dive into that. We're going to be talking about OCDs today. Osteochondrosis dissecans. Mm-hmm. You know, this is one of my favorite topics. Believe it or not, actually, I love OCDs.
I do enjoy them as well.
I love the development of them. I love how we treat them. Just everything in general about it. It's just, I love joints.
Yeah.
So this is a really cool topic.
Well, and I mean, when you think about a horse and their performance, coming down to the joints is a very, very important thing to maintain the health of. So
I mean, number one cause of poor performance in horses is lameness. Mm-hmm. The number one cause of lameness, joint issues.
Yeah.
Whether it's OA, OCDs, the list goes on.
Yes.
So when you really think about it, save the joint, save the horse. So, yeah. Let's talk about OCDs. So, osteochondrosis dissecans, we're going to be abbreviating that OCD for the rest of this time. Let's talk about what that is and how they form and jump in there.
Yeah, so ultimately, to simple it down, an OCD is essentially a malformation. So it's a disruption of what we call endochondral ossification in our joints. So we're starting from the time that they're a fetus within the mare in utero, and then during their growth, it's an inconsistency in the growth at those cartilage and at those faces of the joint, more commonly in certain joints than others.
Yeah, when you think about to understand an OCD, you've got to understand how a joint grows. Mm-hmm. So we know how a leg gets longer.
Right.
But when something has to make the joint surface get bigger.
Right.
And it's in a term called endoossification. And what that means is we get a growth of cartilage.
Right.
And then right behind that growth of cartilage, we get calcification.
Right.
So there's always this cartilaginous covering, and the body's just calcifying as it goes. And so that makes the joint get larger.
Right.
So the joint surface get larger. And the issue comes when calcification doesn't occur.
Right.
So they end up not calcifying that piece of cartilage. It ends up breaking off.
Yeah, or you get flaps that may not be completely dislodged from the
Or it could be a
surface.
cystic lesion where there's not. So there's kind of three different ones, right? Yep. And I hate the term joint mouse. They call it a joint mouse.
Yeah, I've heard that a couple times, but that's not been my go-to.
No, that was when I was in school. They say, oh, you got a joint mouse. And I always hated that because they don't look like mice, I don't think. I don't know why they call it that.
I mean, maybe just because it's the pesky little thing in the corner. I don't know.
Yeah, but that's where you actually get this cartilage that doesn't calcify, actually completely breaks off and separates from the joint surface itself.
Right.
It ends up attaching to the joint capsule, getting a blood supply, and calcifying there.
Right.
And so it's like this little fragment of bone hanging out in the joint.
Right.
That's one type.
Right.
The other one's the flaps you talked about, where part of it, the underlying part doesn't calcify, but the top of it sort of does calcify.
Right.
Just enough to create this little flap right there, and it's where it's not fully attached, and it's just like we're describing. It's a little flap. Maybe Casey can throw some different pictures up for those of y'all watching on YouTube. Then you got the cyst.
Cystic lesions, yeah.
And cyst are where you end up deeper in there. You have a larger area that doesn't form, and then it kind of I equate it almost like looking at a little balloon inside the joint, like a balloon of cartilage, and you've got an entrance where fluid can go into that cyst, but it can't get back out.
Come back out, yeah.
And those horses get quite painful. So those are kind of your three major kinds.
And those, I feel like you see more of a variety of treatment options than in your other types.
I agree. The cysts, there's a lot of different treatment options. We'll get into some of those later on. But, one of the things we've learned over the years is, because we go through, the question is, why do they form?
Right.
How do they form?
Right.
And we used to think it was about foals growing too fast, which it does occur in
contributes, but
right, faster growing breeds.
Right.
But a lot of it's been traced back to intra-utero nutrition.
Right.
How these mares are fed when these fetuses are developing.
Yeah.
And so let's talk a little bit about that, developing these OCDs, and as we go through, we'll kind of talk about what you can do to try to minimize your risk.
So, like Dan mentioned, we need to be considering how we're feeding these mares while they're pregnant and how we're promoting the growth of the fetus, and it ends up becoming a problem when we're growing these essentially too fast, and we're not giving the actual normal physiologic processes of laying down that bone the time to go through the right steps in that bone.
And given the right building blocks during
Right.
that time, we talk a lot about calcium and phosphorus ratios, especially in foal and yearling diets. But it's really important in those brood mares to make sure that diet is balanced to where you have that calcium and phosphorus ratio where it needs to be. Because that's when it starts, right?
Yeah.
Like when this fetus is growing, we're developing bone.
Right.
They're born with bone, so we got to make sure that mare is fed properly, and I think that's a big thing that gets missed now.
Well, and we think about, like, this is actually, like, I guess a question for you is, do you think that becomes even more important later in gestation because of that, in that last essentially stage, they're laying down a lot at the later process?
Well, I think it goes back. You've got to remember when you get into that last, I always hate trimesters, but that's kind of how we group it.
Kind of how it is, yeah.
When the majority of fetal development occurs in that last trimester, well, here's our problem. Mares cannot physically consume enough nutrients during the last stages of gestation and the first stages of lactation to meet the demands, to meet their demands. This is why mares will often lose weight during this time.
Right.
Because there's so much fetal development going on, nutrient demands are so high that they physically cannot consume enough. Their stomachs just aren't large enough.
Right.
And so really this comes about nutrition before you breed.
That's a good point, yeah.
So we got to start talking, you're thinking about breeding. What body condition score does my mare need to be in?
Yeah.
Where does she need to be from a micronutrient standpoint? Where does she need to be from calcium and phosphorus? And then there's other micronutrients like zinc and copper that also play a role in this.
That help, yeah.
So really, when you're going to breed, you've got to think about all this.
Right.
So having those mares prepared for that last trimester. I guess if you think about it, you do all your prep work, and the last trimester will be what it needs to be.
Right.
And then same thing, like your milk content, your milk nutrient content will be what it needs to be to help these foals grow.
Yeah. It's kind of, I guess, like, it's kind of like training an athlete. Like, if you don't do the training early, then, gearing up before the game is not going to get you there.
Exactly.
But if you do the training leading up, then your gear up is not too bad.
That's a great point. If you're going to run a marathon, you don't start training the week before.
No. Yeah.
Yeah.
No, I always end up running back to athletics to make the analogy. So
no, that's absolutely true. And like I said, I do some consulting on the side for for some breeding farms, and one of the things I look at a lot is these OCDs.
Yeah.
I learned years ago it goes back to this inter-utero nutrition.
Yeah.
And that's going to be the nutrition of these mares, making sure that's right long before you breed the mare.
Well, and I know a lot of people have questions about if it's actually genetic and if they should breed different horses, but I do think that the nutrition aspect might be a stronger role, even if there is some underlying genetic involvement.
I guess what I look at on that,
Yeah.
I think it's a combination of both.
Yeah.
We see it in our faster growing breeds.
That's true. Yeah.
Thoroughbreds, quarter horses, certain warm bloods.
Certain warm bloods, yep.
And if you think about it, the body can only calcify cartilage so fast.
Right.
We've selected for horses that are growing faster in some of these breeds.
So that they can perform better
Right.
earlier in their career.
If you look at a lot of the Western disciplines, they've got the futurities at 3.
Oh, yeah.
You've got the race horses that are racing at 3. And so they have, over hundreds of years, we've selected for horses that develop faster.
Right.
Because they have horses that are able to perform at a younger age.
Right.
And so I think that's the genetic component.
Right.
Or and this is theory according to Dan, which gets you really nowhere. This is just observation. But if you look at those faster growing breeds, that we tend to see this. And I think their cartilage at the end of that joint is growing faster than what the body can calcify.
Right.
And so I think that's kind of the genetic component.
Yeah.
The nutrition component, and I think this is why we focus so much on the nutrition. This is something we can do
That's
something
the part
about.
we can control.
Right.
Because, to your point, being more breed in terms of genetics as opposed to this mare, this sire,
Right.
we can control the nutrition, and that's how we can modulate what's going on.
When I've even seen it in standard breds, that's what I've done a lot of work in. And if you look, we've selected before, if you go back even 75 years ago, the focus wasn't so much on the younger horses racing. Like there was a focus there, but it wasn't as big of a deal. And I feel like now that we've focused a lot on the 3-year-old year for these horses, I feel like now we're starting to see an increase in OCDs in standard breds.
Well, and looking at the research because a lot of the research about OCDs is in your racehorses, whether
Right.
that be standard bred or thoroughbred. And looking at their performance, we see less difference or less change or less impact as they get into their later years too. So while like your point is, focusing on training them for racing for their performance later as opposed to younger, we're also seeing that, maybe these could or could not have impact earlier in their career depending on how they're treating them.
Right. So I think you got to kind of look at the holistic approach and know what breed you're dealing with.
Right.
And then, again, focusing on how you're going to feed that mare. And then once that foal's here, what do you need to do to feed that foal? And then even up to the yearlings. And this is where I think if you're going to breed horses, I think it's really important to find a nutritionist that deals in breeding horses. There's a lot of, it's just like vets, right?
Right.
You got vets that are surgeons, vets that are internists. You've
Nutritionists.
got nutritionists. And it's no different with nutritionists.
Yeah.
You've got some that focus on athletes. You've got some that focus more on those brood mares and
Right.
feeding babies. And I think you've got to find that person that can help walk you through that, really look at your diet,
Right.
and get you where you need to be. And then, working with your veterinarian and your nutritionist, say, okay, I'm going to breed my horse this spring.
Yeah.
What do I need to be doing now? I mean, it's August right now.
Yeah.
But really, now's the time to start prepping
Right.
to breed in the spring. This is where it starts.
This is your preseason.
Right.
Yeah.
So I think finding that nutritionist to work with is really important. There's some great nutritionists out there that can really help with
And
this.
I think it's one of those things that, and I think it's so funny is you see people, for example, in like the dairy world, that having a nutritionist to help them with their production and all of that is like a really big deal in the cow world. But I feel like we underutilize it sometimes in the equine world.
I agree so if you, I've had the most weird career to become a veterinarian, but I actually started as a ruminant nutritionist. That was
No way.
that was
I
actually
didn't know that.
yeah.
You're doing a nutrition talk on this podcast at some point, aren't you?
I think so.
Yeah.
But I started as a ruminant nutritionist. I was going to feed cows, and I did ruminant nutrition for a while. Then I became a farrier. But you're absolutely right. I mean, from the beef cattle side, the dairy side, whether we're grazing or working in a feedlot, there's a nutritionist involved.
Yes.
Same thing with every other species. There's a nutritionist involved. In horses, I think oftentimes we don't focus enough on getting that nutritionist involved to help our athletes. And I think it's incredibly important, depending on what you're doing, how you need to feed that horse. So get a nutritionist.
Yeah.
Bottom line, go get
Get
you
a
a good nutritionist. So, that's a little bit how OCDs form.
Right.
And where I really want to go with this is let's talk about, all right, we've got an OCD. What do we do?
Right.
And this is where I think it gets pretty debated.
Oh, yes.
And
Well, and there's also the research that, in some of the research that's done just looking at performance based on OCDs or not, in terms of, if you screen your horse, how are they going to do at their job? A lot of those studies don't actually have the did they get treated or not, because they're looking at sale rads or something along those lines and performance statistics. And then there's, obviously a few studies that, hey, these were treated conservative, these were treated surgically. But a lot of the real numbers that are out there, you don't actually know what treatment was done.
Well, and a lot of the work's done in racehorses.
Right.
And I can tell you, when speed is added into the equation, it completely changes things.
Right.
All right, so if you look at like a fetlock chip.
Yep.
A lot of your sport horses can perform for a long time, and I don't think it's a good idea, and we'll get into that later.
Right.
They can perform at a long time with minimal effect in performance with a fetlock chip. You get a racehorse, this horse is not going to perform.
Right.
Once speed's added into the equation, this
Right.
horse can't perform. And so I think it really matters what your goal is and what you're planning to do.
Right.
So let's talk a little bit about, you've got an OCD, what's the big deal?
Right.
A lot of people are like, what's the big deal? And especially I hear this a lot, like, well, the horse is sound on it.
They are right now.
Now.
Yeah. So, when you have a lesion like that in a joint, you have inflammation that's going to continue to develop. And as that inflammation develops, then you're going to have secondary changes in that joint that maybe it's arthritis, maybe it's synovitis, but it's going to progress over time and become limiting if it's not right now.
I think to understand it, you got to go into Dr. Bramlage, Larry Bramlage of Root and Riddle. He would always talk about debris.
Yes.
Debris in the joint. There's physical debris. That's actual OCD itself, or the
Right.
chip. And then there's physiologic debris. And that's what happens because this foreign body, this OCD's in there, is a foreign body in the joint. It's causing a release of inflammatory mediators
Right.
that cause a release of these digestive enzymes that actually degrade joint cartilage and actually tear up joint synovium.
Yep.
And both of these are going to lead to deterioration of the joint.
Right.
And so, yes, as a 4-year-old may not be a problem. What about when horse is 13, 14,
Right.
15? And this is where a problem starts to show up. And these joints can start to degrade over time, shortening careers, shortening performance. And so, this is one of the reasons that this physiologic debris, we talked about this in a earlier podcast about why we inject joints. And it's the removal of that physiologic debris.
Right.
But as long as you got physical debris,
You're going to continue to have physiologic. Yeah.
if we get rid of the physical debris, guess what? The physiologic debris goes away.
Yeah. You
So
remove the source.
get rid of the problem.
Yes.
So screening.
Yes.
Get asked this question a lot. Now,
Yes.
in the racehorse world I work in,
You essentially have to in the
We have
racehorse
to.
world because of sale rads.
right? We go through every April. Every yearling we've got in April, we radiograph all those. If they've got them, we take
We
them
take
out.
them out. Yep.
So screening proponent. What are your thoughts?
I think it's beneficial to know. In some people, in some disciplines, what they're going to do with their horse, it may not be one that, obviously in the racehorse world, especially for the sale, whether it's because it's changing their performance or because it's the thought behind it, everybody wants their horse clean going into the sale rads. So you're going to take those out. So yeah, screen them, take them out. You're having better performance at the sales, that kind of thing. But even if you're not going to do something about it based on what that where the chip is or where the OCD is or how severe it is, and what the horse is going to do. Having the knowledge that it's there and being able to track it, for example, like say you have one that's pretty mild, and we talked about this the other day in a younger horse, and it may be faintly being there in a stifle, but not a big old cyst. That might be something we could monitor as opposed to jumping in and trying to do something about right now. It's good to know what you've got going into training this horse into what they're going to do.
Well, that's one of the things to look at. Now that we've got digital radiographs, it's easy.
Exactly.
I mean, it's
non-invasive.
easy to screen. Right. It's easy to screen. If we go back when, every time I do one of these, I feel like I'm the old guy, right? Because when I was first in veterinary medicine, digital radiographs were not
a thing.
I remember I had one of the first ones in Georgia.
Yeah.
Now, back then you had to shoot film, so we weren't screening these horses.
Right.
And so the story was always the horse goes off to training, gets to training, starts working, and the joint blows up.
Gets effusive, yeah.
Then the joint gets x-rayed. Now we found this, especially hocks, those dirt lesions,
right.
The distal intermediate ridge of the tibia. The joint blows up. Take an x-ray. Oh, it's there. Now we got to go send the horse and get it removed. Well, we're 3 to 4 weeks into training. Now we got to stop training.
Now we got to rehab.
So then we got 6 to 8 weeks of rehab on the backside, and then we're finally back to work. We just wasted time.
Yeah.
And so if you're talking about a horse like a futurity horse or a race horse where time matters, you just knocked out 2 months, and you're already on a tough timeline on these young horse events. And then you just took out another 2 to 3 months.
Right.
And so I think especially if you're looking at doing some of the young horse stuff, screening these horses is critical, and get that done before they go into training.
Right.
Like I think I don't know about you, but like 18 months is like
Yeah, I mean,
12 to 18
because really you're going to see those within the first 12 months. But at the same, like to your point, you probably don't need to, unless they're going to sale for a racehorse, they probably don't need to be necessarily dealt with in that first year. There are some that are, maybe it's a flap and it does have the time to stick back down and ossify, and maybe you get away with not having to do something with that. So I think 18 months is very fair.
In a lot of the barns I screen in, it's done based on scheduling the stalls, right? Because there's a period of stall rest after you have OCDs out. Well, we have this break where brood mares are out of the barn and yearlings haven't come up to be prepped.
Yep.
So we've got stall space.
Yeah.
So that's why we love that April, May, June. Yeah. That's a great time for us to do this.
Right.
Because most of our brood mares, we don't need stalls for brood mares, and we don't need stalls for yearling prep. So we can get those out. Plus, that gives us enough time for that horse to recover. We can get those yearlings prepped. And so 18 months is kind of my magic window. Let's screen them. And in the majority of cases, if they're there, let's get them out.
Yep.
Get them out now. It's going to improve the sale value of the horse.
Right.
It's going to improve performance of the horse. And it's going to improve lifespan of the joint.
Yep.
Which is a better career.
Yeah.
And, used to these were big surgeries. You had to completely open the joint and physically look at the joint.
Arthrotomies.
Yeah, arthrotomy. So that's where you actually cut into the joint and go do it. And a guy, he's actually one of the guys that I actually did a arthroscopy course with him. There was a guy, Wayne McElraith, out of Colorado State. And he was doing his residency. And he'd heard about human surgeons doing arthroscopies
minimally
in joints.
Invasive, yeah.
And he begged and pleaded with his major professor for his residency to let him go. Well, there was 100 people in that course. 99 of them were MDs, and Wayne.
Sounds about right.
But
hey, if you want it, go get it.
Yeah. And it was crazy because the first arthroscopies, you actually look through you put the scope in the joint with a light source, and there was no camera. You look through what it was the equivalent of a microscope, the little piece on a microscope where you look through. That's what you visualize the joint with. No cameras.
Hey, you still got your eyes in the joint.
Yeah, it was insane when he was showing us pictures of how they did this. And then we finally got cameras, and You know, the great thing taking these out is so minimally invasive now. I mean, 2 small stab incisions.
Yep.
I mean, we're taking these out with 2 small stab incisions. It's one of my favorite surgeries to do. You're looking at it up on the screen. I mean, it's...
Yeah. In my training so far, you know, surgery was kind of what I wanted to do with my life, and I decided to come here and work with you instead of doing another internship. But I want to get better at arthroscopy for sure.
I'll tell you, it's a great tool, and it's just fun.
Yeah.
It is fun to do. I don't know why, but you get inside the joint.
It's instant gratification.
Oh yeah, because basically what we're doing when we deal with these, let's say if we're dealing with a straightforward OCD lesion that's got a little chip in the joint.
Yeah.
We're basically going in with a camera, finding it, elevating it off of wherever it's at, and then grabbing it with a pair of rongeurs and pulling it out of the joint. Mm-hmm. Go through with a curette, clean it up.
Yep.
Come out.
Yeah.
And I'll be honest, taking them out, you know, with a minimally invasive approach, and then I love regenerative medicine after I've removed these. Things like Prostride and IRAP, this is even stem cells. This is where I'm a big fan of it. Because when you go back in and look at some of these joints afterwards, it doesn't come back with a normal cartilage. It comes back with a fiber cartilage. But these joints look fantastic. Mm-hmm. It's like nothing ever happened. And so it's really interesting to look at the combination of the two. And that's been coming for about the last 5 or 6 years. We've been using a combination of the two of them, and it's working really, really well.
Yeah.
And like I said, most of these horses never miss a beat. It's about 6 to 8 weeks of downtime, and they're back ready to go again. So,
definitely feasible.
Definitely.
And without wasting too much time.
Right.
If you get to them at the right time.
That's why I like get to them before you go into training. It's my thought. And then if you're selling horses, go look, because a buyer shows up and there's an OCD in there, they're going to be worried.
Right.
And every veterinarian out there, if we're looking to set of pre-purchase films and there's chips in there, we're all over there going,
Yep.
We're going to cover our butts, right?
Oh, yeah.
And we're going to say, this has got some risk.
Yeah.
But if it's not there, and I think all of us, if we hear the story, here's pre-surgical rats, we had this. Here's post-surgical, they took it out. Mm-hmm. The horse is sound and doing fine.
Yeah.
None of us care.
Right.
We're moving on. We don't care if you had it taken out. We're glad you had it taken out.
Well, and on the other side of that a little bit is, you know, to what we're saying, removing them, they have a really great prognosis by removing them, that if we do pre-purchase a real young horse and we see something like that, we may, you could have the end of having risk. We also could have the end of, we got to do something about it. But if you're willing to do something about it, then great opportunity.
Right. I've had many of them. I've done I've done several where we see them, they're in there, and literally we buy the horse, and the next week
put
we
it in the barn to go do surgery the next day.
And like I said, these horses are going to have great careers.
Yeah.
So, which brings up an interesting point. I always say there's some I worry about, and I'm going to caution you with, and others I'm like, what's the big deal? We'll go and grab it, take it out, move on with life. Have you seen the same thing?
I feel like the ones that get a little more wary are the stifle cysts.
100%.
And depending on how old the horse is, because we obviously have different ways we can treat them. And yes, you can treat them when they're older, but in my experience, which is very minimal compared to your experience, when we see a 2-year-old with a stifle cyst, throw a screw in it, does pretty well.
Right.
You see a 3 or 4-year-old with a stifle cyst, you want to throw a screw in it. It doesn't have that same level of, at least in the ones that I've seen, it doesn't have that same level of, recheck rad a couple months later, already starting to fill in that cyst kind of response.
I think it has to do with those younger horses. That bone still has development.
Right.
It's still actively developing. Like, it's ramped up. It's supposed to be growing.
Well, yeah, because the theory of the screw is that we're doing some, I guess, minimal trauma to that area, and we're saying, hey, body, lay down more bone here. Right. So when you already have that production going on, like you've already got the factory working, and you say, hey, factory, we need it over here. Yeah. And those young horses, it does really well. But when we're getting a little older and maybe that factory is not putting out as much as it used to, then I think it becomes more of an uphill battle to try to get these horses sound again, especially if they're already lame because of it.
And I think it's interesting we brought up stifle cyst because I can think of 3 different ways off the top of my head to treat a stifle cyst.
Exactly. And that's the other thing about the cyst, like that we mentioned before, is it's not just a pluck it out and clean it up and call it a day. Those we have to get a little bit more creative with.
No, it's one of my favorite approaches. And if we've got time, and this is why I like screening.
Yeah.
Because if we have time, we can try a few things.
You like stem cells?
No, but what I do like, it's a little old school, but
Yeah.
I've been really successful with it, is we actually go in ultrasound guided, find the cyst,
Yeah.
use a spinal needle to go
Inject the cyst.
Right, and go into the cyst and inject it with depomedrol.
Oh, okay.
And that, on a lot of those, it has about the same. And when you get into cysts, so I got to be careful what I say because, when you get into cysts, there's so many different things that we look at to determine, the size of the cyst, the size of the neck of the cyst. There's a lot of things that go into prognosis, but a lot of those early studies looking at intralesional injection with depomedrol, those horses did as well as surgical debridement.
Right.
So if we've got time, because again, like you're talking about with the screw, we need to get that in there early if we're going to do that. But if we got some time, we can try an intralesional injection.
Right.
That's done just quick surgical procedure, 15 minutes. We're the only thing going in the joints and needles, so it's no different than a joint injection.
Right.
And it can be quite successful. But if it doesn't work, having that time on the backside to where we can either look, okay, we need to go surgical debridement or we need to put a screw across it,
Right.
gives us a lot more options.
Yeah.
And the screw's an interesting one. Like,
You leave it in or you take it out?
If it's in there, I don't take it out unless it becomes a problem.
Because some have the theory that as you take it out, you then promote that bone laying down even more. So some like to take it out. They're like, it's almost filled in. Let's pull it and let's send the factory sources to that site again.
My question, and I've debated this with a couple people.
Yeah.
I wonder, because it's the screw going through that cyst that tears up the lining of that cyst.
Yep.
That gets the factory back involved repairing that bone.
Right.
Could you just run the screw through there, back the screw out, and let it heal?
That's a great question. I don't know.
I've always wondered that, and I've asked it, and I posed it to a couple people.
Yeah.
And everybody's like, well, I don't know.
Because I think, to some extent you wonder about the kind of, because the cyst is essentially an empty space.
Right.
The stabilization of leaving that screw across while the bone's laying down.
Mm-hmm.
Because you're immobilizing that ability of that bone to potentially give a little, that maybe that's why people might not.
That's the theory everybody's said, but it kind of makes me wonder because it goes back to the old school way.
Yeah.
You would actually go in with an arthroscope, find the cyst, and you just use a bone curette
And just
scrape
scoop it out.
Just scoop the cyst out, and those horses heal back into fine. I remember when the screw first came out, we were all like, "Dude, what? Like, it's gonna lay a screw across this thing, and that's gonna fix it?"
Yeah.
And like, who even came up with this? But
Probably some guy.
Yeah, I've done it. I personally haven't done it, but I've had it done in several stifles.
Yeah.
A couple pastern cysts, and it's been it's been pretty successful.
Yeah.
But I do wonder on some of these pasterns. I kind of wonder, do we need to take those out? I feel like those might be more of an issue than like the stifle screws.
Yeah, taking the screw out later.
But it's become common enough. We do a lot of off-the-track thoroughbreds here, and you'll go through doing rads on them on a pre-purchase, and
There's a screw.
there's a screw.
Yeah.
And I don't think a lot about it.
No,
So-
I mean, as long as the cyst isn't still,
Mhm.
completely see-through,
Yeah.
then I think we're all right.
I
That
agree.
screw's not going to hurt anything.
Nah. And so then it becomes, I think the other thing we're talking about, these OCDs, like we talked about a little bit with stifles, but it's kind of like real estate, right? Location, location, location. Because what's interesting, let's get into another one that can be a little controversial, or I
Where are
shouldn't say
you going with this,
controversial.
Dan?
I'm going to the fetlock joint.
Yeah.
That's my favorite joint of the whole horse, right?
Which part are we talking?
Well, two main locations we see this. You got what we call the dorsal chips, the one up in the front of the joint, and then we have those palmar plantar chips. The ones in the hind legs seem to be more common, those plantar P1 chips. And then that gets debated. Are these chips or are they OCDs?
Yep.
And I'm talking about if you want to have a good discussion, get somebody that's firmly in one camp or the other, and get a few beers on the table and listen to them to debate that, because it is. Veterinarians actually get really intense. Like the nerd starts coming out, and it gets into a very heated debate on, are they a chip from trauma, or are they an OCD from development?
Don't ever tell a surgeon you got an OCD in a carpus.
No, that's a chip.
That is a chip.
And I feel like the fetlocks are the same way. But yeah, so we got the two big ones. There's several others, but the big ones, that dorsal P1 chip, or the one in the front of the joint, and then that plantar or palmar.
I feel like you got to give a third. I feel like you got to give a third for that proximal sagittal ridge.
Yeah, that's true.
And there's debate on those too, in how you want to go about them.
Yeah, I agree. What's your thought? Like, what did you see? I mean, because you worked in a big practice out in Texas, worked up in Indiana.
In my experience there, we were more concerned about the front of the joint than the back of the joint. The thing too is sometimes we'd get in there with this free floating chip, and we'd be looking around the joint, and we can't find it. It's already embedded in some soft tissue somewhere, and generally in those cases, surgeons were okay with that because we're not floating around disrupting the joint.
Talking about the plantar chips, the ones in the back of the joint.
Yes.
Yeah.
So in that standpoint, if we're in there and we can't find the thing and it's on the back of the joint, we decided not to be too worried about it. Now, obviously, if we were doing this for a sales situation, then you really try to get everything, so you got a clean horse going into sale. But
yeah, I got the same kind of opinion. I like to take in the three. I never use the word never.
Right.
I never use that word in veterinary. The only time I use the word never is saying I will never say never.
All right, Justin.
So I like to say always, maybe, rarely.
Yes.
So the sagittal one's up top on there's a little ridge that runs on the fetlock joint, and it's kind of up top in the fetlock joint.
Right.
Seldom do I ever take those out.
Okay.
I don't see them really causing an issue. The ones in the back of the joint, that's a maybe.
That's a maybe.
That one's got to prove it needs to come out.
And your P1s are your always.
That's my always.
Yeah.
The ones in the front of the joint seem to wreck. They cause the most havoc.
Well, and then what's interesting about that is because I went back into some of the papers. I'd already read most of them at some point. But I went back into some of the papers, and interestingly, I think it was one of the thoroughbred papers. It might have been a standardbred, but I think it was one of the thoroughbred papers. Found the sagittal ridge to actually be the one that was significant. And I thought that was really interesting because in my experience so far in the surgeons I've talked to, those are the ones that we're not as excited about in terms of becoming a problem. Yeah. I think that was probably coincidental.
I agree, because like that sagittal ridge one, like there'll be these little tiny chips at the top of that joint. And I just don't see them causing that much of an issue.
Yeah.
Those dorsal P1s, those
are a problem.
Yeah. The ones in the back of that joint, Dave Frisbee said this, and I'm going to agree with him. He's like, if you have an athlete that's in the top 10%, like if we're looking at the top 10% of reiners, top 10% of jumpers, top 10% of dressage, whatever it is, top 10%, then those chips will keep them from reaching their full potential. But the other 90% of horses, they don't cause an issue.
Right.
And then the real challenge is getting those out. Those are not easy. Like you said before, like you'll get in this joint and trying to find this thing is difficult because it gets embedded in that joint capsule.
Right.
And it is not the easiest thing to get out.
Well, and are you just doing more damage chewing up your joint capsule to get to it?
That's the debate. So it's got to prove to me. Like this chip's got to prove to me that it has to come out. Plus, if you look at like the secondary effects of the joint, like if you look at these horses that have had these plantar chips, for 15, 20 years, you don't see the amount of OA in the joint or arthritic
Right.
changes in the joint as you do with those dorsal or the ones in the front.
Yeah.
So those get out.
Right.
And then I think on that same thing about, which ones cause the problem, I think you have to look at the age of the horse as well when you find these.
Right.
If a horse is 15 and we find a dorsal P1,
If they're having problems.
Yeah.
But if they're not, then.
well, and my thing there is like the damage is done.
Right.
Joint's trash, or I shouldn't say joint's trash, but
If it's going to be trashed,
if it's going to be
trashed
trashed
at that point.
right? And because I do have a few of those rare horses that have had a dorsal P1 and that fetlock's still fine.
Mm-hmm.
Now that's not the majority of them,
No.
but some of them do. But now if I find that if you got a 6-year-old, I'm going to strongly encourage you, let's get this thing out.
Right. Do you have a strong feeling on forelimb fetlocks versus hindlimb fetlocks?
Depends on the
'Cause
discipline.
There's some debate that the hind limbs are less of a problem than the forelimbs, but again, a lot of the research is racehorses.
Well, and that goes back to the discipline. The two big horses I work on, dressage horses and jumpers, on jumpers. And one of the things I like to say a lot is a dressage horse, it's all about the hind fetlock. Like,
Right.
it's all about the hind limbs. The front legs on a dressage horse are there to look pretty. The back end does the work.
Yeah.
So I think in those horses,
The
it's
hind,
critical,
yeah.
hind. Jumpers, that's your landing gear. You got to be comfortable landing. When you're not comfortable landing, that's when we start swapping.
Right.
We start having trouble with leads. We start drifting, things like that. And so,
So you think the landing is more detrimental than your takeoff?
I think it shows up there.
Okay.
I mean, you can still see it in the takeoff on those horses.
Yeah.
But the front end, the ones up front seem to be more of an issue.
Okay.
And again, this is observation
This
according
is your
to Dan.
experience,
So
yeah.
this is like, this will get you nothing in life, but it is what I've seen.
Yeah.
So, and a lot of times people are like, well, what else can we do if we don't want to do surgery? I was like, well, if you don't want to do surgery, we should probably do surgery. I'm going to push. And
Yeah.
then the real debate comes in like, I don't want to do surgery. Can we just inject it?
Yeah. I mean, you can. You can inject whatever you want.
Do I think
But-
it's good?
No.
No.
Because then, I mean, if we cycle back to talking about these OCDs and why we have to do something about them anyway, okay, so maybe we reduced some of that physiologic debris
Today,
but the source of the physiologic debris is the actual foreign body that's still sitting there.
and it's just going to keep ramping up.
Yep.
You're constantly in here. Now, again, I think it goes back to age. Again, if your horse is 15 and it's got one of these, there's at that point, the destruction of the joint, if it's going to occur, it's happened. So, yeah, we're just going to manage this thing as long as we can.
Sure.
But let's don't do that on a 3-year-old.
No.
Like, you got to, or a 5-year-old.
Not with that much time and that
Yeah.
much real estate to work with in
Yeah.
their training.
Because especially if you look at some of these disciplines, like in the jumper world or even in the dressage world, that 12 to 15 are your golden years in these
Yeah.
horses. I mean, that's when they're like really, I guess jumpers like 8 to 15, but really 8 to 15, that's when your training's already come through. The horse knows what it needs to do. This is the prime years of its life. We don't need to be sitting there trying to manage a problem
Right.
during the best years. And that's also when you're going to see more of the destruction of that joint.
Yeah.
So let's get this thing out. Let's just get it out.
I
Let's
agree with you.
Be done with it. But can you? Yes. Some people go as far as to say it's malpractice to inject a joint with a chip.
I mean, that's a bold statement, but I understand like the mentality behind saying it.
Right.
Because you're not removing the problem. You're just quieting the joint while it's getting physical damage to it.
Right.
So,
But again, if the horse, you've got to look at everything. Horse is 15,
yeah, it's
like just
full picture.
whole picture. You got to look at things, age, what it does, Yeah, I think that's also important is what the horse does. Mm-hmm. Like I said, we talked about speed's a problem. So these barrel horses, these are a bigger problem than barrel horses. Jumpers are a bigger problem than hunters. Anything with speed makes these worse. So there's a lot of factors. And so I think that's why it's important, like, talk to your vet about these things.
Of course.
Make sure you've got a vet that's knowledgeable on them and talk to them about it, because it's the question is not as simple as I have an OCD. Now what?
It's not, because you have to have that full picture. Where is it? Mm-hmm. How old are we? So how long has it been there? Because these are developmental. So the age of the horse is essentially the age of the OCD. Mm-hmm. What are they going to do? Because, we talk about speed, but you also think if you've got a horse that's, let's say they're used for trails, but they're doing 10, 15 miles a day, that's enough wear and tear for it to become a problem.
Right.
And like everything is its own circumstance. And
mm-hmm.
yes, we have trends in terms of let's get them out. That's the trend. Mm-hmm. But in terms of when and where and what you're going to do, that's really you need the whole puzzle to make the decision.
Yep. I agree 100%. I think it's something you need to know, and I think it's something you need to understand how it's going to affect mm-hmm. you and your horse. So if we're going to kind of sum this up, and I swear every time we do something like an OCD topic or some of these topics, I was like, well, that was just a high-level overview. I could have taken each segment of that and talked for like 3 hours, but we're going to have to come back to this and talk a little bit more, do a little bit of a deeper dive. But if you had to throw some takeaways out there, like if people get just like 3 things, what do you hope they understand?
I would hope that they understand what an OCD is and how it gets there, mm-hmm. like the importance of nutrition like we talked about. I would hope that they understand that we can do something about it, so that if they find it, that there is a way that we can treat that, and that knowing it's there is highly valuable information, mm-hmm. better earlier than later.
Right. I'm going to say something very similar. One, let's try to prevent them. So if you're going to breed your mare, let's start working on that nutrition 6 to 8 months before breeding. Mm-hmm. Use a nutritionist. Mm-hmm. Be prepared when you breed. Mm-hmm. 2, if you have them, like screen early. If you're going to breed, I think part of responsible breeding is screening those horses mm-hmm. for OCDs. Mm-hmm. So screen those horses and get them removed before you start into training. Yep. Let's give that joint the best opportunity it has. Mm-hmm. Plus, let's don't have to have a pause in training. Let's don't have 60 to 90 days that we should be training. Let's don't spend 60 to 90 days of those recovering from an OCD surgery. Right. Let's do that before. And I guess the next one is talk to your vet if you do have one of these. Mm-hmm. Understand the full picture. Because I can tell you, young Dan I didn't care how old the horse was, chip, OCD, get it out. I don't care. 20 years old, take it out. Dan has been around for a little while longer. We're going to think about some things.
Sure.
So, but no, I think that was a great topic, hitting on OCDs. I can nerd on this forever. I love joints. But just want to thank you for being here today, Dr. Tori. Yeah. For all the listeners out there, thank you for making this possible. Y'all keep sending your questions in. We'll try to get them answered. We just appreciate everybody listening. Thanks to April for getting this recorded. Casey for doing all the edits, because there's a lot of them, I think.
I think we did pretty good today.
I mean, we did pretty good today. Some days, I think Casey's just like, how am I going to fix this? So, but thank you, everybody, for being involved. We look forward to seeing y'all next time. From all of us here at Countryside Equine Hospital and the Equine Vet Connect, y'all have a great week. Take care.